Hello, everybody, and welcome to another episode of Realign Healthcare. With us today, we have Dr. Margaret Lozovatsky, pediatrician, informatician, digital health innovator, and incredible leader who is helping to drive healthcare innovation. She's currently served as a vice president of digital health innovation on AMA. Margaret, welcome to the show.
Thank you for having me. Thrilled to be here.
Margaret, we usually start with the journey because the journey is define who you are, how do you think, and how you can contribute to the field. So tell me a little bit about how did you end up leading digital health innovation for AMA and how your professional career, especially on the clinical side, help you to better get a perspective.
Yeah, it's a great question. When people ask me this, I usually tell them that never in a million years would I have envisioned my career to lead me here. And yet I love what I do. And so, like many of us, I went through the typical medical training and finished my residency in pediatrics right around the time that electronic medical records were coming to be. I had a computer science degree. That was my undergrad education. And so I quickly found myself at the center of these conversations because I really wanted to make sure that technology supports our needs. And from very small projects when I was trying to get the weight in the header for pediatric patients so I could take care of them, to larger projects, I quickly got involved in optimizing technology. I've been at multiple systems, multiple CMIO, CHIO roles, rolled out a bunch of EHRs, started in that space, and really began to understand how critical it is for us to have that clinical understanding of what the needs of the physicians, the nurses, all of the folks at the bedside are in order for us to be able to implement technologies that can support our needs. And after spending many years being on the implementation side in the CHIO roles, I received a call from the AMA where I felt that this was an opportunity to think about it at a national level. And so here I am leading the digital health team at the AMA.
Right. And we're certainly lucky to have you in this role, but why AMA? Like some of us are members, some of us are not. And sometimes we see what's happening and most of us know AMA from billing codes and other things that you guys do. But why AMA? Like what's AMA is currently doing for digital health innovation?
Yeah, that's another really good question. And when I first received the call, I had a lot of conversations with my current leader at the AMA about the direction that they're in. So I should back up and share where I sit at the AMA because I think that will answer the question of why. I am part of what we call PS2, Professional Satisfaction and Practice Sustainability. So we're on the mission side of the AMA, and our team's entire focus is to support physicians in what their needs are. Of course, we know that today, probably the top thing that we hear from physicians is that they're struggling with many of the technologies that are out there. And so as my role continues to grow, because the needs become larger and larger, this to me was a huge opportunity to think about how do we support physicians today with the current uses of technology, because we know that that's necessary, but also where's the puck going? What do we think about in the future is going to be the trends that we can begin to get ahead of to ensure that we continue to support physicians in this space?
And frankly, the speed of change in a practice is just incredible. If you go back in 10 years and the way practice changed between, I don't know, 1990s and 2005, for example, in 15 years, was mostly on the clinical side. You'll get new medication, you get new procedures, something else. And that was one skill set. Now you constantly have your EHR updates, you have new digital health application and other things. So from a physician perspective, like how do you even adjust to rate of the change? Because you had a computer science degree, right? You're by definition technologist because people who are afraid of technology would not go and take a computer science degree. But a lot of the clinicians are not technologists, and frankly, until EHR was deployed, were even afraid of a technology, and still may. So how do you start combining and leverage, some of the value of a technology without producing the fear? Because the sentiment being mixed frankly, until maybe ambient start to appear about the impact of technology and the burnout related to a technology. So where do you think there are opportunities and how physicians kind of can stay ahead in this game?
Yeah, when people ask me what I do day to day, what I usually tell them is that a very small fraction of what I think about is the actual technology. Because technology exists today to support a lot of what we're going to be doing, so much about the people in the process and the change management. And so I still practice. I see kids in the hospital a few times a month. And every time I walk into the hospital, I feel it. I feel the stressors. I feel the fact that things are changing very quickly. And I recognize that we have not yet moved to a place where the technology is truly there to support my ability to care for patients. So many things have gotten better, right? I'm no longer chasing down vitals across the hospital. They're all right in front of me. The data gathering phase of the change has happened. But the reason I think clinicians struggle with the rate of change is that we haven't gotten to a place where we really feel how it is supporting our ability to provide the best care because there's still a lot of hiccups. And that's why I'm so interested in this work is to decrease some of that burden. We talk about cognitive burden, all the things we have to remember. I feel like technology is ripe for supporting that, for allowing us to get the information that we need in real time in a way that we can digest it. We just have not gotten there yet. So when clinicians ask me why should I stick in with all of these changes, my answer is that it is a journey and we're not at the destination yet. And the more that we can support this journey and we can listen to what people truly need in the clinical spaces, the more successful we will all be. And so that partnership has been really instrumental in our ability, I think, to do some of the change management that is so challenging to your point.
That's an incredible insight, Margaret. And frankly, I think it's on clinician for us. And I know it's very hard to find time, but to help to redesign new breed of technology. Because let's be frank, the current generation, at least the widely spread current generation of technology, was not necessarily designed with a clinician usability in mind or designed to minimize cognitive burden. And it's got better. Like even our EHR system that we've been deploying in 2010 is drastically different compared to EHR system we're using now. And, vendors, frankly, been spending a lot of time, right, to learn from those patterns. But a lot of the workflows are still broken. And we're trying to automate a lot of the broken. So how do you see the evolving role of clinician and the doctor in actually helping to ignite this transformation? Because frankly, if we will not aggressively intervene right now, there is a real chance, and frankly, that's why Realign Healthcare as a podcast was started. There's a real chance that we'll automate the wrong things and create another system that we are not happy with, and we'll say, oh, we don't like yet another system. But amount of resources being invested right now is high. So the desire to build something new is also high. So now is opportunity to intervene. So where, how, so it's clinicians start contributing, and how do you think it's may reshape the overall landscape?
Yeah, it's an important question. And the more years I spend in this field, the more my opinion on this also continues to evolve. But where I think we are today is what we did is we took paper and we put it into a computer screen. And we didn't know what we didn't know, right? We took our paper workflows, the SOAP note. Why does the SOAP format exist? Because that's how we were gathering that data to then ultimately come up with an assessment, to put it all in one place. That no longer makes sense in a computer system that has all the data on the back end. Maybe we don't need to document in the same way. But the reason I think we are where we are is not bad intent. It's the fact that the technology moved so quickly that we didn't recognize that we couldn't take our old processes and translate them into the current technology. And you're absolutely right. I think about this all the time. We are at the start, I would say, of the revolution of how quickly the technology is going to transform care. And if we don't do this differently this time, we're going to struggle. And what has happened over the years is we have had physicians that have gotten engaged and that have learned from what has happened and have gotten training. We now have a board certified specialty called clinical informatics, where there are physicians that are trained in doing this work. And I think that we have to really leverage that expertise where you have practicing clinicians that understand the technology piece and engage those physicians in a different way. So back in the day, we had the CMIOs that were mostly at the elbow support. They would tell you which button to choose and what's going to make your day faster. And today, we truly have executives that understand the bigger picture of what an institution needs, what a clinician needs. How can you leverage technology in the most effective way possible? And integrating those individuals into a system is going to be really important to be the person setting the strategy for how technology is implemented. And just as important is keeping some of these decisions close to the care. So while you may have an executive who is a pediatrician, they need to make sure they're partnering with a cardiologist and their technology informatics knowledge is partnered with the cardiologist that understands the needs of a cardiologist. And it's really in that partnership, these multidisciplinary structures, where I think the magic is going to happen in leveraging technology in the most effective way possible.
Collaborate, expand your teams, and share the wisdom. I think it's a great recipe for collaborative innovation. But frankly, I really like the insight about the EHR and starting with a SOAP note, because in a time of ambient, in a time where we can meaningfully extract the structured data, right? That's if you remember 20 years ago, that was a dream from non-structured text. Uh, is frankly a reality. It's getting better, not just every year, like every week we see something from a DeepSeek and other model that's being released that's now on par with our colleagues, right? Sometime even performing way better than a physician without AI by itself. So a lot of the notes we used to write now playing more of a supportive function. It's for helping us to properly think through the clinical case, and not necessarily is kind of informational, because there is easier way to generate some of that. That's also going into a lot of the notes we share with our referral letters and insurers that frankly used to create a lot of a bureaucratic burden. So from ambient technology, or frankly anything that's coming from the AI, like where do you think we have this, applications in the areas where we can help physician to get closer to the bedside and help technology to kind of take over the rest of the bureaucratic burden that's been created over the last, several decades?
Yeah, I think there's a few areas. The technology that exists today is really, it's ready to start to decrease some of the administrative burdens, right? It shouldn't take a physician to write a prior auth note when all the data is in the chart. Some of this stuff should just be automatically created with us reviewing the information. The technology that exists today is also ripe for empowering team-based care, because it can allow us to get the messages to the right team member, and it can learn some of these patterns so that we are not sending everything to an in-basket. We're reimagining what our communication pathways are. I mean, the in-basket today is sort of a hole that everything goes into, right? From tasks to order cosigns to patient communication, everything is just thrown in there. So how can we rethink team-based care in a thoughtful way such that we can utilize everyone at the top of their license? Well, AI can really help us with that. When it comes to documentation, that is top of many physicians' lists for burden, right? It is challenging. I know I myself, being in inpatient medicine, often come home and finish my notes because my days are so busy. And gosh, as I think about the utility of those notes and what the EHR can truly do, to me, it goes back to redesigning the way that we're using the system, and it becomes almost like a data repository, right? The responses to ambient have been amazing. People are saying that it saves their marriage, that they can have dinner with their kids. And I think that it is the first step, because right now it's still recreating a SOAP note. So let's take a step back and really think about what is the purpose of a note. And it is a two-way communication tool, right? That was the original purpose. It's now used for billing, it's used for other spaces. Can we have the system generate these secondary use case reports for whatever is necessary from the data that it stores? And can we take it a step further? Can we now think about, I like to call it a precision EHR, if you will, EHR that presents the data to me in the way that I need to see it based on my specialty, and then taking it a step further based on my needs as a human. We are all different phenotypes. Some of us are visual learners, some of us are auditory learners, some of us want to see it in a graph format, some of us want to see it in a table format, whatever it may look like. But imagine a day that instead of writing a SOAP note, we're inputting ambient data into the system, and it then provides us with an output that allows us to trend our patients over time. And someone asked me a very thoughtful question actually a few days ago about this. What happens to all of that processing that happens in our brains? How do we communicate that? And I don't think that ever gets lost. I think of it as cognitive synthesis of the physician, right? That's what we practice at the top of our license. So let's use the EHR for that level of communication rather than all of us retyping vital signs and lab results.
This is a dream. Like as a clinician, like frankly, and again, the listener know I was trained in Eastern Europe, and I practice not just on paper, but like fully on paper. It's mean there is no computers anywhere. Um, and your note always being like the reason why you duplicated your labs and things, it was frankly for you to see that, right? Like the nurse will write it down before you. So that was the method of communication. And in the recreation of the note part, we lost the information part, right? Like we created a lot of the noise, and I think noise is harming the system, significantly harming. So coming up with documenting the actions, like what I did and what was my thought process, if that's relevant, because in certain specialties, specifically oncology, for example, documenting your thought process and why you decided to go there may be more important, right, than my sinusitis that time I see in urgent care, for example. And that's a different way of practice. And I think what I particularly like about that, especially, I'll start using precise HR term now, so pardon for that. But the precise HR becoming my tool that augment me as a clinician. It's not becoming this, some instrument that's constrained me, right? And as a physician, right, I have to get my practice patterns into this tool that's make me less efficient, right? And frankly, get me out of a bedside where I cannot even talk with the patients, but help me to be this like real assistant, right? Like my PA or MA would be next to my shoulder screaming, you forgot to say this or ask about this. And it give you relevant information. So I certainly see the chance where the role of the EHR may change. And let's talk about the business of medicine, because there is no way around it. And unfortunately, the business of medicine define a lot of our clinical documentation practice. And frankly, even when we talk about ambient, that's been well received, but there are still debate about exact ROI, which to me, frankly, is mind-blowing to a certain degree, right? Because physician happiness is going up and we're still asking question about the ROI. Like, I'm not really sure that's exactly like, economic impact, how we can afford is a different one, right? But I think the ROI exact question is may not be the best one. So how do you see some of the billing practices change? Because it certainly resonates, the part where everything that's necessary from the documentation perspective may be generated. But then I think that the challenging part here is you either have information enough to generate it or you do not. And we know that sometime machine learning system right now, especially predictive one that we use for generative AI, tends to hallucinate, right? Or create things that's not there, or predict something that's not exactly true. And then it's coming right now under the name of a clinician. So we certainly will be distorting some of the, you know, current practice, right, in the billing patterns. So how do you think we can create both transparent, clear, and automated system? And by the way, feel free to go as crazy as you want, from let's just be a single payer system to let's actually get rid of denials, right, and the pre-approvals, because frankly, I'm not sure that's in a purely learning and integrated system, a lot of this is required in a current way. Um, so
Yeah, all really good questions and good points. If we go back to this concept that has always existed of if you didn't write it down, it didn't happen, we start to really get to the root of some of the causes of why we felt like our notes needed to be 12 pages long because we had to document everything that happened. And then with ambient technology, we can eventually move to a place where everything that occurs is then automatically put into the EHR as a data repository or whatever the system is, right? We can call it this new version of clinical technology approach. And so if we have a record of all the things that have occurred, then it's a different ballgame, if you will, when it comes to billing, because at the end of the day, then you are billing for the things that happened, right? There's no questions. You don't need to take all those extra steps. I mean, we talk a lot about prior auth. We know that it is a really challenging problem to solve, and yet there the reality is that right now incentives are not aligned with providing optimal care. And so until we can really truly move to a value-based care model, part of the challenge is the fact that we're not getting reimbursed for some of the work that we're doing. And that's not a problem you and I can solve with technology, but we can certainly streamline the way technology supports clinicians when it comes to billing, right? That's where I think we can help think through what does this new version look like. We talk a lot, I mean, to your point about ambient, we talk a lot at the AMA about how to evaluate these technology tools in a slightly different way, because of course the first question is how much is this going to cost me and what is the ROI? And we've developed this framework called Return on Health, where we look at ROI, of course, from a financial perspective, because that's a part of it, but also thinking about the quintuple aim holistically. So what is the impact on patient experience, clinician experience, quality, patient outcomes, right? Which is our endpoint measure that we should be thinking about. And then, of course, health equity, which runs across all of these work streams. That allows for a slightly different conversation as you're thinking about bringing these tools into the clinical environments, because then the value can be translated into all of these categories, and it's not purely a financial analysis, if you will. At the end of the day, patient quality translates into dollars too. Clinician turnover certainly costs organizations a lot of money, so you can always translate into dollars and cents, but it allows us to have a little bit more of a rich conversation.
I think the role of trust in a healthcare is incredibly underappreciated. Like we had this big pull to consumerism, and we decided to take the worst part of consumerism. Like let's just try the race to the button, high throughput, the cheapest more accessible to a certain degree, right? But less differentiated and personalized service out of consumerism. But forget that a lot of the part of consumers is also the brand and the trust and the higher quality of the standards as you can get. And some healthcare systems, the major one, may be leveraging that significantly to their advantage. But I think we also forget about the trust that's going back to the brand of the hospital to the clinicians. Because every time I interact with this, and at some point when you remember EHR was implemented, some physicians were rejecting job offers, right? If the EHR was not in place, or if it was not EHR they were expecting. Uh, and like a lot of this trust that need to be built between the leadership and the clinical team is based on technology and a decision related. So I really like the return on health's new frameworks because it's helped to portray this not only in a financial perspective, because frankly if you just look on ROI, then the cheapest way is to go to the AI driven care as fast as possible, right? And just give you access to the cheapest, lowest quality, right? Or lowest affordable quality you can get. And that's how you get the ROI. And if you miss the points, you miss the point. The interesting part, frankly, and what concerns me a bit, so it would be interesting to kind of get your perspective, is if the learning system and you get, pre-approval and we accept that, even if it's a generated document, um, frankly, the only person who wins are cloud providers because we're putting one AI from the payer perspective against another AI from the healthcare perspective. And when I talk with insurers and payers, even on this show, they don't really want to do pre-approval. It's not like, because from the medical perspective, we're like, this is all coming from the payers. Payers are bad, and of course I'm exacerbating. But we like to kind of put a lot of the blame at players lose money in a lot of that. They would love not to have it, but this is being created as a mechanism, right, to align for overutilization and understanding better some of this. Because frankly, we do have scenarios where some of clinicians were abusing the system. So now if we have a shared knowledge base, if we have a EHR that's very separated, right, for the proper reasons, how we can better care jointly for the patient without getting into the arm race of AI technologies that actually will just make things more complicated and potentially increase the costs instead by decreasing.
Yeah, we talk a lot at the AMA about the fact that this is clearly a concern, right? That you're going to have AI talking to AI, and that's how prior auth is going to evolve. I don't think anybody wants that to be the pathway. And as we think about the future of how healthcare records are collated, again, if you have ambient technology that is really gathering the events that happen during the healthcare interaction, and maybe the interactions look different, right? Some of them might be virtual, they may be more team-based. Hard to say how it's going to evolve, but definitely we have to also get past the whole physician and patient model being the ultimate interaction. What are some asynchronous ways that we can interact? Then we can start to really train some of these technologies to evaluate outcomes. And hopefully that will speed up the transition to value-based care, to really looking at the bigger picture of how do we support patient outcomes rather than these transactional interactions that exist in our current environment.
Hmm. While we're talking, I had a startup idea. So if anyone getting it from this podcast, please ping us. Um, Maybe we just need a trusted third party that has access and actually acting on behalf of the patient just to ensure it's appropriate. And instead of just doing this collaboration, maybe an agentic system that's just driving this in a real time without us actually going back to extremely rudimentary methods of communications, faxes. Like what drives me crazy, frankly, Margaret, sometime is we have a AI on both sides to interpret images that we send via fax technology. Like, how ridiculous is that? Is like AI extracting the data to generate the note, to print it and send through the fax, for this to be once again character recognized through OCR, evaluated, and then made a decision to generate yet another fax. And ultimately, we're decreasing it to this level of communication. To me, this is madness. So let's switch to the to the more positive part around that. So things are changing. Ambient is coming here. Frankly, AI. If we had a question, is AI real? Maybe a few years ago, right? That it's not a question anymore. AI is real. AI can help us to solve problem. We just need to find proper operational framework to bring it. And let's return back to the physician role, because we historically, a lot of us who didn't really have computer science degrees, right, or were not primed to go into the informatics, um, still questioning, right, the decision. I spent 5, 10, 15 years in postgraduate training. Why should I go into administrative? Because it's coming very often with a pay decrease, right? Because you're spending more time in administration, but your impact is different. Like, why do you think people need to consider sharing some of their bedside knowledge with the wider communities, and what can we do to actually encourage clinicians to participate more?
Yeah, I think that there's many ways people can participate, and that's the beauty of this. And our learnings from the bedside are so critical and will continue to be critical as we think about administrative roles. And so, of course, I want to make sure physicians continue to practice medicine. And I also want physicians to love practicing medicine. And part of the transition to this administrative world, and I don't know if that was similar for you, but for me, it allowed me to have an impact at a system level in a way that I didn't always have. I still, like I mentioned, see patients because I love that and I don't want to give that up. That is a really critical part of who I am. Whenever people ask me, what do you do? I always start with, I'm a pediatrician. That is my identity. And it allows me to understand the experience of that clinician when I am thinking about bigger system challenges that we're trying to approach. And so what I say to people is that the way that you get involved may look different for everybody. It may be a committee. It may be written email input that you give us, but don't underestimate the importance of sharing what you're experiencing when you're caring for patients. It's so important to take a step back and really think about, what do I need to be more successful, to be able to care for patients, whether it's faster, more effectively, improve your outcomes, or just decrease the cognitive burden that you're experiencing on a day-to-day basis. Just thinking about the challenges that you are seeing every day and being able to communicate them is really important. And if that kind of difficult question interests you, of how do you solve those problems that many of your colleagues are going to bring to you, then these administrative roles allow you to tackle really challenging but interesting problems. And they allow you to have an impact at scale to really help your clinicians. One of the first tools that I helped implement was a solution for bilirubin management that was designed by a fellow pediatrician, and we put it into the EHR and integrated it into the workflow. People were hugging me in the hallways. I mean, it is very satisfying to be able to support other physicians, nurses, all of our clinicians, as we know they are experiencing so many challenges when they care for patients.
I think this is spot on. And frankly, putting more of my consultant hat, the first thing that you would tell to any startup that's want to work is actually not just find your champion, but find the champion that's obsessed with your product. It's not just someone who say, okay, I'm going to find 1 or 2 hours every other month to listen to your pitch and just give you feedback, right? The person need to have, fire in their eyes about this, right? Like, I do relate to this problem. I actually want to keep working on that and have come up with idea. And I think that's the biggest challenge for a lot of the startups and the product. And it's also create a lot of opportunities for clinicians, because I think this feedback loop at some point between the clinicians and the hospital administration and frankly vendors and service providers was lost. Because if you go, one of the reasons for burnout is this, the perception that it doesn't really matter, right? Like, I will get my survey once a year and we will all click that we are not very satisfied, and then nothing will happen beyond the town hall. And a lot of this is changing, and a lot of people do look for your voices. So even, if some of you listeners may perceive that you're not being heard, doesn't really mean that you need to stop trying. Ultimately, this may lead to success, and I think there is a lot of forces that's helping. But on top of that, now is the opportunity. Now is the opportunity to find this, technology and innovation or vendor or a committee that will allow you to bring this change. Because what I see a lot in the market is how much easier now is to start developing technology. Like, let's look at your bilirubin tools. Like, I've built calculator. That's where all of us started, right, in informatics. And for some of us, for us, it was asthma management. That's my mentor, Rick Schiffman, back there was working. So we're looking into the way to bring into the Epic connected to the data. But it was hard, right? Like, you remember, is like find not only web development, right, but a front end person, and then integrate with the EHR. They did not have any API connectors, and it was incredibly complicated and a long process. Very long, very hard. Now what I see, physicians, even with rudimentary amount of coding, no computer science, go into the automated coding agencies and creating smart on fire application that's ready to be deployed into the EHR over the weekend. So this ability not only to build things, right, but actually do it yourself and kind of do it fast, bring us completely different part of the innovation. So my question to you right now is, now we actually disintermediate a lot of the services, right, that's traditional informatician provided, and allow a lot of clinicians to kind of start becoming builders in this. Like, how do you think it will change? What else can we do it to support our colleagues?
Yeah, I think that the more of our colleagues get engaged, the more we will be successful in identifying the actual problems that are out there, right? I like to call them the pebbles in our shoes that every day, the death by 1,000 paper cuts that we're experiencing. And the fact that these solutions are so easily accessible now is both a blessing and a curse, right? It's kind of like when we're really excited about the fact that we could customize things. And yes, sometimes it's really necessary. And then we over customized and it became a curse. So what I would say is that it is now more important than ever to have very clear models at organizations for governance, for decision making, and to have those experts at the table that have both the clinical understanding and the technical understanding that really can lead the thoughtful integration of all of these tools. Because we are a little bit of in danger, if you will, of creating a monster that has a lot of really smart, thoughtful tools that don't work together. And that actually, in my mind, will create much more burden than if they don't exist in the first place, because you know that workflow is everything. And if we don't have thoughtful workflow design, we will struggle.
deaths by 100 pilots, right, or by thousands application. I certainly see this, right, and most of us CMIO, CHIO have a lot of scar tissues, right, from potential colleagues who developed something, right, or did anything else, and they think it's a best thing since it's sliced bread, and unfortunately doesn't integrate. It's not validated, right, and can frankly at scale produce way more harm than the benefits, right? But just communicating it back is pretty challenging. But going back to your previous notion of a personalized EHR, right, and this precision EHR, and especially now when we have not just wildly supported Fire, right, but we have all the use CDI and Smart on Fire is working better, and CDS hooks are finally more than just implementation guidelines and specification. Maybe it's time for better sandboxes. Maybe like the biggest challenge for a lot of this project was I couldn't really enable it for the N of one, right? So if you as a anesthesia um, develop something that's allow you to pre-screen the patients and you think it's helping you in your practice, the reason why a lot of this was not deployed, for example, is because when we go to the committee, the IT committee or anesthesia committee, they're looking at that saying like beyond one person, no one's going to use this, right? And it will change a lot of the workflows. But that's because we are obsessed with one unified workflow. And one unified workflow on average is helpful, right? But then what if now, with an easy integration that decreases the burden on IT, we may start allow physician developers to actually build things for themselves that's supervised and easy to deploy. Do you think that will change some of the way we practice and develop?
I think there's certainly a possibility that we will have more flexibility in how we develop these tools for the N of one, if you will. There's a lot of literature out there that shows that autonomy is at the center of burnout, the lack of autonomy specifically, and that we as physicians who went into this field because we want to care for patients have certainly felt this loss of autonomy because one thing at a time has been torn away from us in our ability to make independent decisions, particularly as more and more physicians are practicing in a healthcare system environment. And so I do think that there's a need for regaining of that autonomy. What that looks like in this new environment of quick iterative integration of technology, I don't know. I think there's a lot of, I mean, you know this, there's a lot of regulation, there's a lot of barriers to allowing for this quick innovation, and yet it's so necessary. Will it come from an individual physician, or will it come from a very configurable environment? I don't know, but I do know that we're going to need some sort of precise approach to our clinicians to be able to support them, much like I can configure my iPhone and it does what I need it to do. I'd like to get to a place where I have some autonomy over my clinical technology environment with all the safety precautions that we know need to happen, right? We need to think about cybersecurity. We need to make sure that the information we're getting is clinically accurate, safety, quality, all of those considerations are going to be top of mind as we consider what the future looks like. But I'm really optimistic that we will have configurability in whichever way it is, and that will bring back some of that joy of practicing medicine that many of us had lost, frankly, over the years.
And credit where due, physician builder programs certainly allow to enable participation, like a wider participation of clinicians in a lot of that. It's I think it was great tool for enabling, right, tech savvy or curious clinician into building and utilizing some of these tools. It's still very technical though, right? So you need to have certain degree of understanding how it works. And frankly, personally, even though I like custom development, I see no way where all of this will be enabled. Is just in the way we currently practice with the data integrity, with security, and the threat and risk analysis, just almost impossible, right? Unless you truly create application. Because frankly, as a person who managed development teams, right, it's not a question about you developing now a great application. It's a question is every application coming with a support cost in the long term, right? Because everything needs to be updated and maintained. Who's gonna be doing that when you're gone? And I think that's where a lot of those custom things are not being approved and analyzed. Yet, I think the point around the platform is a critical one, because historically we had EHR, one big conglomerate, right, of a very hard to modify things. We got a physician builder program that's got better, right, but it's still relatively constrained. But what's happening now, and I think, newly released Microsoft Dragon documentation is a great example, and there is like more and more application are coming. A lot of those tools allow you to design your next generation custom workflows. That's almost like physician builder plus, right? Something that's allow you to kind of pull the information, and ultimately in the core of our activity as a clinician, it's just pulling, analyzing information, and then creating differential diagnosis, pre-drafting things for you. So we starting to get this new generation of a tool with way lower risk, right? Because there is no maintenance problem. You're still having a platform part that will allow you. So I think I'm very positive around this. And which bring me to very important part that I would love to discuss with you, which is in kind of core for the whole Realign Healthcare podcast, frankly, is frankly the fear that's in all the excitement of a new technology revolution. We just put AI and our new technology on the broken processes without thinking about it and asking critical questions. Do we truly need any of that? Right? So because where can we learn more about the processes? And how can we help organization and individual practices and clinician to actually maybe document and understand more? Because I'll share a small anecdote in my consulting practice right now. When I go to the healthcare systems or even work with the startups around, let's build AI for X. The biggest challenge is not even the governance. It's common. The challenge is this hard to me explain misunderstanding of what's really going on in your process. You may get a process from A to B and have 5 people involved, right? And you realize this is likely where things happen. But you're not only not sure how many steps, you're not even certain about what exactly every individual contributor is doing, what's a success criteria. You just know something happened, right? So it's like black box after the black box after black box. And that's a horrible target for automation, because you don't really know what's going to happen afterwards, like how it's successful. Your success criteria defined by what? By the person receiving after 5 black box steps kind of saying it looks pretty good enough, right? Like based on this example, like you cannot capture your tails and failures scenarios. So what can we do to better learn about our processes? Because otherwise we're doomed just to put, mindless automation on top of a broken system.
I like to say that we're putting Band-Aids on a gusher. We keep replacing the Band-Aids. They're really not getting all the blood. I think that we have gotten to a place where there's been a lot of effort to document these processes, and yet they're changing so quickly and they're so individualized to everyone's environment. And frankly, no one's following the processes anyway after they've been documented, that I would argue that instead of documenting what is happening today, let's take a step back and say, what should the process look like with the technology that we have today and with the technology that we have coming in the future? I'll give you an example. I just gave a talk at HIMSS. We called it, Are We Paving Cow Paths? because in Boston and other cities, but Boston's a really great example, the way that the roads were developed was that the cow paths were paved, and those are existing roads today. And of course, anyone that's driven in Boston knows that it's a challenge because obviously it's not the ideal way to think about urban planning. And so today, people are talking about building roads not even for the current environment, but how do we think about building roads for what will exist in 100 years? So how do we make sure that there is wireless charging for electric cars in our roads? And that we support drones, for example, that are going to be a part of our environment. We in healthcare have been paving cow paths. How do we transition from the cow paths to future urban planning? And to me, that is by rethinking the processes from scratch. What do we need to do when we're admitting a patient? Let's work through the steps that should exist. And let's ask the question of every step that we're doing today, is that the right step? And then rethink both physical environment and technology applications that will support what we're trying to achieve. That's really been our challenge. That's kind of how we started this conversation about the SOAP note. That is a very common cow path. We are still thinking in a SOAP format. How do we transition to looking at this data repository that will present us information in real time? And to me, that is the transition from the cow paths to the urban planning.
And you mentioned that earlier. A lot of the cow path in our clinical practice engraved because we believe that that's a requirement, right? Like a lot of the over documentation happens because some individual contributor either know or believe that this requirement. And frankly, as an informatician, you had multiple examples, right? Like, for example, when we were redesigning the notes templates, where you would have almost a fight between your team members saying, we cannot absolutely remove this section because this section is required based on this. And then you go into the guideline, none of this actually exists, right? So it's like a local legend that it's required and someone is believing. So this is a classic example of this cow path-like stuff. So who do you think need to take the role of redesigning some of those cow paths? Because this is certainly a very uncomfortable. And I think Boston roads are a great example. You cannot go to the Boston and say, you know what, let's redo our urban planning right now, right? And it's a little bit easier in the healthcare systems, hopefully, than in Boston, which means it's possible. But who do you think need to take a leading role of that? Is it a function of the government? Is it a function of individual healthcare system leaders? Or maybe it's need to go from grounds up?
I would say yes, yes, and yes. Everybody needs to be engaged in this. This is clearly a multidisciplinary approach. This is not you and I had some ideas, we're going to go redesign the way we deliver care, right? Because you really need the various perspectives. And so where I think this is going to start is probably at the individual organization level / practice, right? So in the care environment where you have some thoughtful, forward-thinking leaders, and it has to come from the top. It needs to be a strategic priority, that those leaders make that a top priority for the system and they delegate people with appropriate expertise. And there are process improvement folks that this is their career to look at these processes. And they need to be partnered with the people delivering the care. They can show them what they're trying to accomplish. The technology teams, the informatics teams, the CFO team that is going to look at the cost of care, legal, compliance. This really needs to be done by all of the leaders in the health system. And that is not an easy task. But I think it's not going to happen overnight, and it's going to probably happen in a stepwise fashion. Just having the conversation is important. And perhaps we're at a point where, with the evolution of AI moving so quickly, it has become more of a burning platform, right? We were never more effective in making changes than we were in 2020 when our hand was forced, right? We went from 5% adoption of telehealth to 100% adoption because guess what? We had no choice. So to me, we need to create a burning platform for this because we know that clinicians are at their breaking point. We know that technology is not providing the value that it could in our healthcare spaces. And frankly, we can't afford to continue down the path we're going. And so building this burning platform, I think, will help people begin the conversation. And I hope in the next few years, we will be discussing how we are on our way to a different approach. I don't know that that will happen, but that's my hope.
I I share the vision, and I think it will happen if everyone will support this. And I think one of the critical elements of making this happen is actually provide safety for the experimentation, because a lot of the questions were not asked about, usability and what's a correct way of doing it, because that's a requirement. And I think we need to stop um, overly assigning legal right value to some of those steps, because the whole fact that historically it's been documented, right, doesn't really mean that's the way it's need to be practiced. A lot of our requirements being built for different eras and different confirmation, and I think we can find easier technology enabled way to confirm this, right, rather than just using the old fashioned phrase in that's will then faxing for the insurance reimbursement. And frankly, I even think that insurers are on board, right? Because I think it's this like prisoner dilemma to a certain degree, where insurers afraid to talk with healthcare groups, right, and providers, because all of this starting a lot of the other negotiation, right, and things like that. And so you never want to do the first mover, in this case disadvantage. But I think we all will benefit in making system easier and lighter. So we're almost at the end of our episode. Time flew very fast. And our traditional question is, if you would have a magic wand, what is the single things you will change in the way our healthcare system work right now for clinicians, patients, or society in general?
I, I think it's a tough question because we would all change many things. If I had to pinpoint something that I struggle with, it's the way that we approach the patient experience from the clinician perspective. And what I mean by that is, I think that we have sort of grown up in healthcare thinking about an ambulatory patient or an inpatient or an ED patient, and we have failed to really understand that it's a patient, it's a human, and thoughtfully design the trajectory of that patient through our healthcare system such that the data around that patient is gathered in a thoughtful manner. It's a cohesive, full picture of what's happening to that individual. And we certainly have not been successful in presenting that information to our clinicians so that they can make the best decisions. And so if I really had to pinpoint where we can have the biggest impact, to me, it's what we've been talking about in theory, which is patient-centered care, but truly making everything in healthcare about the needs of the patient and the outcome of that patient, and helping our clinicians, empowering our clinicians with the information. And part of that is interoperability. Part of it is the way that we deliver that information. There's so many pieces to this: the patient experience, the way they interact with the healthcare system, access challenges, all of that, I think, will evolve when we shift the narrative to really make sure that the patient is at the center of every conversation. And I hope that a lot of what we discussed today will get us closer to that vision that I have for how we can best care for our patients.
I certainly hope so. Uh, Dr. Lozovatsky, thank you for joining us for the Realign Healthcare. It's been a great episode, and I'm looking forward. Keep following your success at AMA, and hopefully in a few years following up just to see where we now and what's new challenges we can address.
Well, thank you for having me and for the really thoughtful conversation.